Hi, everybody. This is Libby Sagara. I facilitate the North Rural eConsult Coalition. We're going to have some folks popping in late, I'm sure. I know it is all hands on deck with clinics right now, and people are spread thin. So we might have a small group. I've gotten a couple of phone calls from clinics, from providers and staff saying that they are wearing many hats. I'm sure you are all too. So as you might know, we record all of these sessions. We post them to our North Rural eConsult Coalition website. If you're not able to attend our 12 o'clock noon calls, we're always available to send these recordings to you if you're not able to attend. But thanks to those of you who've taken the time to join us today. If you wouldn't mind, if you're on chat, if you could introduce yourself using the chat, that would be great. If you are new to our group, please do let us know. We do want to know if you haven't been part of our coalition in the past. I'll run through our agenda quickly. We're just going to spend a moment introducing those who are new to our group, talk very quickly about our goals, since many of you are participants and have been participating in a while in our coalition. Every month we spotlight a clinic who's an active user of eConsult and really is doing their best to incorporate this into their clinic's workflows. And you might have seen our newsletters. Most of you get our newsletters on a monthly basis. We have asked all to participate in a survey on their eConsult experience, and we drew a name, and we'll highlight and announce that winner of our survey drawing. We have the Confirm Ed team on today, and they're going to present a use case on GI. And we will remind everyone of our CME opportunity that's coming up on behavioral mental health, specifically highlighting cases for child and adolescent sake. So we do have some specialists who have provided some great services, a great program called the CAP program that we'll talk about briefly. And just make sure that you're all aware of the resources that we provide, and just really glad to have you on our call today. I know how busy you are. So with that, if we do have any new participants, please do take a moment, introduce yourself. I think we have UC Davis on today. Thanks so much for joining us. Tammy, I think you're UC Davis. Anyone who wants to introduce themselves, please feel free. You're always welcome to pipe up and unmute yourself during the call too. That would be great. This program is supported through funding from Anthem Blue Cross and California Health and Wellness HealthNet. So we appreciate that leadership to make this program possible. And I welcome your input. Those team members who are on our call today, please feel free to share your thoughts. We meet on a monthly basis. Our North Rural eConsult Coalition has now grown to, I think, around 15 organizations. You just saw on our last slide. We're open to anyone who wants to join to hear about eConsult, discuss best practices, figure out how to better support our providers, which are primarily FQHCs, also rural health clinics and Indian health centers. So we meet on a monthly basis to provide support, education, CME. We, over the past year, have really tried to drive policy support for eConsult. We understand reimbursement is necessary to make this sustainable for you all. We stood up a bill last year, State Bill 365, to support primary care provider reimbursement. Unfortunately, it made it all the way to the end, did not pass, but I know that there's interest in reintroducing a bill to support California primary care provider reimbursement in 2022. So we'll keep you abreast of that in 2022. We're really working to make sure that all clinic patients can get eConsults. As you probably know, through Anthem and California Health and Wellness, your Medi-Cal managed care patients have access to eConsults, and through a grant from Anthem, you also can do eConsults for uninsured. But we understand we want consults for all patients, so we're working toward that. And we understand there are always challenges and questions around billing, so we're happy to answer those questions as they arise too. We appreciate you all for really standing up this program, providing clinical and operational leadership, and to the plans and IPAs who do that too. Through our growing program, and as it's grown over the past year or more, we're now able to share the data that's produced by Confirm Ed and by the plans to show a dashboard of increasing provider adoption. So we're just so glad to see that this arrow keeps pointing up. And last, this model is growing, and it's being shared across the country. So we started out as just a small group of providers in the Central Valley eConsult Coalition. It grew up to having another coalition in the North Rural region, which is you all. And now we're expanding support into Sacramento. We'll talk a little bit about that later today. Any comments, any questions, comments? We might have some input from our plans. I'm not sure if California Health and Wellness, Anthem, if you'd like to share anything here. Great. Thanks again, folks. If you are on chat and you want to introduce yourself, if you're a new participant, thank you so much for taking a moment and sharing that you're on. We want to be able to share some common language around e-consults. It's a new concept to many. A lot of you have been doing this for 5 years or more, but for providers that are new to e-consult, we want to remind them that this is an idea or a tool to be able to improve access to care for patients who would not receive that care otherwise, or would have long wait times to receive that care. So what we like to use as sort of our standard statement on e-consult is it can be the first step to a specialty referral. A non-urgent, routine, non-procedural referral requests can be sent first as an e-consult. With that, the primary care provider maintains the relationship with the patient, gets to decide whether that e-consult is appropriate or not. And we have seen some great data around this. I think anyone who's monitoring our data can correct me if I'm wrong, where over 75% of our e-consults are able to be managed without resulting in a face-to-face visit. So it's just some great data coming out of this program. When an e-consult is recommended as a face-to-face visit, so the e-consult might be responded to by the specialist who recommends the patient is seen in person, then it goes back to the clinic who can request that referral. So we understand some patients do need to be seen in person, but we're seeing great data on this being able to prevent unnecessary travel, time off work, and just a real great service for patients. So you've seen we've grown. You can see our list of clinics here. We do have a website. It's econsultworkgroup.com/North Rural in the lower corner here. If you want to check out our website, I mentioned our publications and our past webinars, our monthly webinars are on this website. And this is a huge group of counties, as you can see, and our group of clinics and participants is growing. So just wanted to give a little snapshot of where we're seeing growth of clinic use or utilization across the North. Our green here are active or clinics that have been launched on eConsult, and the gray are those that are in conversation trying to get eConsult up and running. We all know that there's a lot of turnover. Staff with COVID are out. We have people moving from clinic to clinic. It's always interesting to see friendly faces change organizations and be proponents of eConsult. So we're really glad to see that happen in many cases. But we know that periodically you may need to re-engage with us. We might be able to help to present a refresher on eConsult at one of your provider meetings. The Confirm Ed team works with you to do this too. We're always happy to answer any payer-related questions and provide any support that you might need. So please do keep us in mind if you do have your monthly primary care staff meetings. We know, I'm sure that there are many topics to cover through COVID, but we'd love to be able to be that resource to be able to back up your providers. And that leads to a publication I woke up to on my phone this morning, and this is not news to you all providers, but with your increased workload, your clinic's increased workload with testing and COVID cases and vaccinations, we understand that you're spread thin right now. So this really rung true to me this morning. I got a call from a clinic yesterday saying that they were unable to attend our call today because half their staff is out and they're wearing multiple hats and they have to work straight through the noon hour with patients. We get it. So we just want to note that this is a resource available to providers to be able to hopefully decrease that stress. And we're happy to discuss how we might provide some examples of primary care support to do that. We have great support for eConsult through California Primary Care Association, so CPCA. That's sort of what rung on my phone this morning, that Andy Martinez-Patterson, a great advocate of ours at CPCA, just reminded us that your staff is being pulled in many directions, in addition to your patient load increasing due to COVID, and we want to be able to support in any way we can. But on a positive note, although El Dorado CHC, although Cinda Lee is not able to join us because she is standing in for an MA who's out with COVID, I did want to highlight that our winner of our clinic drawing for the survey that Cinda Lee completed, we're just happy to award her that drawing, a $25 gift card for completing our survey. We really appreciate it, and highlight that El Dorado CHC has been an active user of eConsult for I guess a few years now, and it's great to have them as really positive advocates for eConsult. So Terry, I think you're on. Terry, are you there?
I am. Thank you so much.
Thanks for
very much appreciate that.
I don't want to put you on the spot, Terry, but I did get a chance to meet in person with Patrick. I went to your beautiful clinic a couple weeks ago, dropped off some materials. I think Cinda Lee was out, but she might have been ill and didn't get to meet her in person, but thank you for your support ongoing.
Thank you. Appreciate that.
And now I'm going to hand it off to ConfirmEd. And so Marianne and Dr. Anderson, I'll hand it off to you, and go ahead.
Great, thank you. Thanks, Libby.
Okay, Dr. Anderson, I'm just going to click for you. So we're happy to have Dr. Anderson.
Actually, yeah, Libby, if you don't mind, as we often are guilty of, I made some last minute changes and added a couple of new fresh cases that I thought would be interesting. So would it be possible for me to share?
Oh, sure. Yeah, go ahead. Thank you.
Okay. All right. Super. Marianne, do you want to kick us off?
Yeah, no, absolutely. So we're really pleased to be with the North Rural area. We've been working pretty diligently since early 2019 in many of the health centers and practices up there. And today we want to talk a little bit about GI, gastroenterology, and what we've been doing, not just in the North Rural, but across California around GI, which from the beginning of, initiating e-consults in California a number of years ago, GI has been something that has been an access issue for practices, for primary cares, as well as a stress on the specialty side. So what we wanted to share was some data of our experience so far, give you a picture. Darren will give you a picture from the clinical side of, what the PCP is experiencing, how they're using e-consults, and what our specialty network is providing back to them to allow them to gain education, to feel more confident in their ability to manage cases going forward, and to really determine what's appropriate to get on the specialist schedule. Because of part of what we're doing in the coalition work that Libby and her team at Blue Path with Anthem and HealthNet are helping and collaborating with is we're trying to get the right patients at the right time to stay in e-consults with PCP management, and then get the right ones onto the specialty schedule to really improve the access so that the time isn't months for patients to be cared for. That's part of our, moving primary care to the future. Would you agree, Darren?
Absolutely. I think when I was thinking about different specialties, when we first started, I'm glad to see that El Dorado was on and El Dorado was highlighted, because I believe, if I'm not mistaken, we actually started working on e-consults with El Dorado in 2015. And AMPLA, that I know is part of the coalition, was two of the first health centers that we started working with in California way back when. But when we first started building a network for California and looked at different specialties, if you had asked me, I would have said, nah, GI is not going to be that important, because most people we send for GI need a scope. They need some kind of a procedure and all of that. And I've been surprised to see that that was completely wrong. So Marianne, I know you pulled some initial data and stats, and I was just looking on our most up-to-date data. I was surprised to see that GI is the fourth most common requested specialty at ConfirmEd across the country. And for pediatrics, it's the third most common. And so this is some of the data that you pulled earlier in the day. Just in the past year, we did 1,000 GI consults, and most of them are in the North Rural and in the Central Valley region of California, with others being in Southern California. And even though my initial thought was, well, most of these, even if they get an e-consult, they're going to say they need an endoscopy, they need an upper GI, or they need some procedure. It looks like that's not true. 69% of e-consults recommended to stay, as you say, under PCP management. That's a little lower than our average overall, which is more like 80%, but it still speaks to the fact that there is potentially significant value in a GI e-consult. And in a second, I'm going to show a couple of examples of the types of things that providers are using GI e-consults for. And yeah, I went through briefly, did just a quick kind of eyeball review of GI consults. And here's some of the most common things that I found. And one of my favorite things to do is to read e-consults and to see the types of things primary care providers are wrestling with and seeking advice. Evaluation of abnormal LFTs was the most common thing that I found. A lot of, and related to that, a lot of questions about, not does this person have alcoholic liver disease, but this person has alcoholic liver disease. How do I manage it? Or what's the next step in my workup? What kind of surveillance do they need? Questions like that. I think liver disease writ large is, far and away the most common thing that primary care providers are requesting referrals or e-consults from GI specialists. Also saw several about IBS. Which I think is great, extremely common, probably underdiagnosed, but how to approach IBS, some new treatment recommendations around IBS, definitely saw some of those. And occasionally, if you've failed or someone's had partial treatment for H. pylori, but they didn't eradicate it, that's another really common question. But I thought what I would do just briefly, I think there's enormous value in actually any of us involved in e-consults, whether we're working for an e-consult company or whether we're a provider submitting them or a payer that's paying for them. I think the consult itself speaks volumes and tells much more about what's actually going on than anything I could say or any of us could say. So I'm actually going to share a couple. I'm going to geek out a little bit on the last one, and you'll see what I mean when I say that. But just to get more of a feel for what these consults are like, because I think you could pick any specialty, but when you dig in on these consults, it just helps to, I think, realize and to reconfirm. All of us are drinking Kool-Aid about e-consults, but look at the consults, and I think they really do speak to why this is a valuable intervention, particularly for providers practicing in rural locations and locations where Medicaid is a prominent or predominant payer, where access is challenging. But even if it's not, I think what you can see from these consults is how guidance from an e-consult can help a primary care provider do their job and keep the patient within their patient-centered medical home in their care. So this is an example requesting suggestions on further evaluation of an elevated AST and an elevated total bilirubin. Please see today's note and lab work. Please include today's note and lab work for 1 year, which was the note to the referral coordinator who was preparing the packet to send in. And I'll leave it up for a second. I'm not going to read through all of this. But I think what you can see is this consult is an example of exactly what we expect and ask of our specialists. Not just give me a list of things that I ought to do, but talk to me about your thinking. What's your assessment based on what you've seen? Why do you think what you think? And provide some education. And you can see most causes of hepatocellular injury are associated with an AST that's lower than ALT. A little bit of educational content to drop in there. And suggesting that based on the ratio of AST to ALT, that supports the likely diagnosis of alcoholic liver disease, especially with an elevated gamma glutamyl transpeptidase. Not reading this to geek out too much on GI and liver injury, but I think to make the point that e-consults have two really important, well, maybe two or three important elements of value, and GI ones do as well. This is a case that in most scenarios without e-consults would have been sent to a gastroenterologist for further workup and evaluation. But what the GI doctor is clearly indicating here is, here's some of the tests, here's how you approach, here's how you think about the case, and here's what I recommend. This patient is now going to be able to be managed in an FQHC, very likely where there's some component of not only medical care, but active attention to behavioral health needs, integrated care, and such as we provide in an FQHC. So this is a consult that was classified as maintained in primary care, and the patient was able to get further care in an FQHC in California. Let me show you another example, because like I said, I think these examples just serve for me just to kind of confirm and reconfirm why we do this. And for a particular specialty, when you're talking to providers and they're asking, why would I ever use this? these examples speak volumes. So this is a case that I mentioned before. This is a smart, hardworking provider who's spent some time thinking about this case, and you can see constipation, abdominal pain, tenesmus. He's thinking, I think it was a he, is thinking about irritable bowel syndrome, and he's consulted the Rome 3 criteria, and he's referenced them here. And he said, by my assessment, he's only met one of the 3 criteria. Can you help me think this case through further? Again, these are what we call cognitive consults. This is a great example of how an e-consult can help this really smart, hardworking, thinking provider work through and approach the diagnosis. And you can see goes on and recommends some additional testing. And then if all of the above, he also did what I often refer to as provide contingencies. Talk about what you think the initial recommendation is or what the initial recommendation should be, but then provide next steps and contingencies so we don't end up having to consult multiple times. If all of the above are negative, I would start with Fibercon instead of Miralax, which they currently were using, goes on to explain why and explain their thinking. If this is irritable bowel syndrome, counsel the patient on the chronicity of the condition and that there may be bad days. The goal is to decrease the intensity of those days and make them less frequent. Really good, solid advice and a simple bulleted e-consult. And again, I think it speaks volumes to what can be accomplished with a cognitive exchange of information that allows the PCP to continue working with the patient, educating and managing them, but with the additional expertise of a gastroenterologist that's been provided. I'm going to geek out for a second because I think it's a little bit of a risk sharing this one, particularly because one of the complaints that we sometimes hear from primary care providers is that e-consults give them a lot of extra work to do. But I just think that this example is such a fantastic example of a really intense gastroenterologist who takes their job seriously and really wants to support primary care and educate them. So on both ends, both the primary care provider and the gastroenterologist kind of geeked out a little bit, but I'll share this one with you and I'll leave it up for just a couple of minutes to digest. But again, this was a primary care provider who had an ultrasound, was approaching a workup, thinking about what to do about what he called an incidental finding of elevated Lfts. Incidentally, does admit to 10 to 12 beers on a weekend, but the PCP was not necessarily thinking that this was related to alcohol, that in this 34-year-old that wasn't the cause of Lfts. And so he was looking for guidance, had been thinking, and I love the way he put this question. Some of our providers ask, what's the best, how do I get the most out of any consult? But look at his question. It was slightly odd that he has elevated GGT. However, his ultrasound showed his biliary system was normal. In addition, other odd incidental finding was an elevated iron. Given these studies, what tests or treatments would you recommend? What differential should I think of? Should he be referred for consideration of cholecystectomy, given polyps, et cetera, et cetera, et cetera? This is a very, albeit particularly detailed e-consult question that I think recommends in the ideal scenario the way these consults are supposed to work. And I'm going to just put up and share the tutorial that this primary care provider received from the gastroenterologist in California. And if you think this is the last of it, there's a second page. So, yeah, I read this and I was like, oh my God. But I mean, what you have here is a very brief tutorial on the workup and evaluation of elevated LFTs in the context of some questionable alcohol. He goes on to talk about why the iron is elevated. And fortunately for everybody at the end, a nicely enumerated plan, further testing and evaluation. Do this, number 1, number 2, and you can see it cut off at number 3. But I think although this is a little bit long and probably the provider took this home in the evening to read through and digest, nonetheless, this was a great exchange of a cognitive consult back and forth. They got the best care for the patient. And this came back 24 hours after the patient was seen. So it really emphasizes, I think, all that e-consults can do. In an value-based environment, in a total whole person funded healthcare environment, this is exactly the kind of exchange that you want happening with all of your specialty consultations, because there's so much that can be done when two providers get together over some digital exchange of data and put their heads together to think through what should be done next. And I think these are the examples that I wanted to share. And Libby, I hope that was helpful. I really do think it's helpful just to dig in on some of these cases and really see them, because they remind us why we do this and what we can get out of them.
Yes, and I welcome questions that you may have for Dr. Anderson. You can either send them in chat or unmute yourself. But my first question, being a non-clinician, Dr. Anderson, as I quickly read your the response from the specialist, it appeared that there were a number of tests that could be performed at the primary care site before that referral took place. So if there was some time before that patient was seen in person by the specialist, at least XYZ tests would be, or labs would be obtained before that patient went to the next visit. Is that what I read?
Yeah, and so most of them, in fact, I'll go back and look at each one of them, but 2 out of the 3 actually recommended keeping the patient in primary care, I believe, and they actually provided, I mean, most of those were lab tests. They were lab tests or imaging that a PCP actually can do. And so, I think we often, all of us, particularly those, focusing on the financial side of this, focus on that metric of prevented face-to-face visits as the key metric. But I think, again, looking at those consults, it emphasizes that's not the whole value of any consult. There's, I would argue, as much value in a consult that recommends all the workup that you ought to do in advance before they get their face-to-face visit. So, and I've had specialists say this, when I get a patient who's been e-consulted before, I've got everything that I need to be able to tackle the case right then and there, rather than send them back 3 times to get a bunch of tests before they come back. So I think, I don't want to say that the prevented face-to-face visit is not a helpful metric, but it's not the whole picture. And these are good examples of that case, because these patients, if they do end up at GI, are going to have an extensive workup in advance that maybe I like to call it turning 2 visits into 1 visit, or 3 visits into 1 visit for the GI provider and for the patient who's having to travel to God knows where to get their visit.
That's exactly what I was going to ask, and because I am not a clinician, I think of it from just the patient convenience perspective of how can we prevent multiple trips to anywhere, right? Like, how can we knock out as many things as possible in one place? So that was great to see in that example. Marianne, did you have any comments on that? Okay, great. I just want to welcome any questions coming in from the audience. Thank you. Feel free to send them via chat. Dr. Anderson, anything else you'd like to say in wrapping up?
No, I don't think so. I think, we continue to look for specialties that you might not at first pass think would have a lot of value as e-consult, and find that there's an awful lot of opportunity after that. We're looking to expand into some of the surgical specialties a little bit further, because there's a lot of times when just chatting, exchanging information back and forth is enough to figure out the best way to manage the case.
I love this example and the detail provided. I hope that is really valuable, and thanks for letting us share your work. Appreciate it.
Sure, my pleasure. Thank you.
So as we go back to some other examples of use cases of e-consults, one thing I want to emphasize is that Dr. Anderson, the ConfirmEd team, and Weitzman Institute, which Dr. Anderson is part of also, we work to provide CME. So this is a really quick example of the types of cases that the team share in continuing medical education courses that we provide. These are free to our participants, so it's just something that we like to be able to provide to make this a valuable experience for your clinic providers. I know a lot of the folks who attend our monthly calls are not necessarily clinical, so you can make sure to share these examples of these 2 little links that I have in our chat if you'd like to share with your providers. The first one is on the Child Psych program. That is what I'll talk about in a minute, and the other link that I have is registration for CME that we have upcoming, and that is on behavioral mental health. So I'm going to go back to my deck, and the example that I mentioned. Okay, so the first example is that I wanted to mention is on the Child Psych Access Program. This is a great collaboration between CAP, which is a program out of UCSF, and the ConfirmEd team to be able to take what was initially a phone consult program, access to child psych experts by phone. So primary care providers able to contact the UCSF Benioff Children's Hospital team to access phone psych. Now we have been able to incorporate through ConfirmEd a hybrid model where providers can not only do e-consult, but phone consults and decide which is preferable in their case. And Corinne, did you have anything to add on that? Okay, well, I just wanted to note here, you can see the workflow, which is just a simple order by a primary care provider that is sent to the UCSF team. that can be responded to either by phone or e-consult, and it can continue the conversation so that the providers are able to either speak live or they can continue their asynchronous conversation via e-consult. So the link that I have sent in the chat is to the CAP program. You also have that in your monthly newsletter. So that is easily sent forward to your primary care providers by email. If you want to copy it from the chat and send it to anyone who wants to register for the CAP program, that's for child psych. Karina, anything you wanted to add?
Yeah, so this program currently exists in over 18 counties and serves over 400,000 patients currently in the North area. So if you're a clinic that's currently participating in CAP, definitely encourage you to reach out to see how we can incorporate the e-consults into your current workflow with CAP. So, yeah.
Thanks so much, Karina. Okay, the other piece that we wanted to share with you is the opportunity to teach patients, to explain to patients how e-consults work. This is a pretty familiar concept now that people have been doing e-consults for a few years or maybe even 10 years in California. Some of you, I think Ampla, Chapaday, you've probably been doing this for a decade now, but it's still a concept that may not be familiar to patients. So we came up with, along with your input, a lot of the providers on the call today provided input to this, a tool to be able to talk to patients about e-consults. So we tried to make this simple, use some graphics to be able to better explain this to patients. A patient comes to a visit, the primary care doctor, which is a concept not everyone understands, that they're primary care providers and specialists, that the PCP decides that there might be a follow-up question, the specialist emails the advice back, and in many cases that will prevent a patient from having to travel to another appointment. But if the patient does need to have a referral, they will still get that referral. And we do want to make sure patients know that they have access to specialists. This is an attempt to reduce wait times. However, we don't want it to appear like that is not an option for a patient. So we welcome your feedback. I went around to a few clinic sites and dropped these off to get some feedback from providers. We welcome any input that you might have. My next slide here, just a reminder, I mentioned earlier on our call that California Health and Wellness and Anthem cover e-consults for Medi-Cal managed care patients. In addition, your uninsured patients have access to e-consults too. So we're trying to make this as streamlined as possible for primary care providers, in that when they think about needing a referral for a patient, that e-consult is an option. So just wanted to give everyone a reminder of the uninsured coverage that's available. And our next step is moving on to Sacramento. So we're excited that we are moving from North State to look at other clinic sites and listen to their needs, hear how e-consult might be a service for primary care providers in Sacramento. And since a number of our clinics are located across multiple counties, we welcome your input. If you have contacts in Sacramento proper, we would love to be able to reach to them to hear about their needs and how we could support their e-consult use and respond to any needs that might be more relevant to Sacramento specifically. So we'll keep you up to speed on upcoming meetings around Sacramento. And last, just we also meet on a monthly basis. I know right now people are spread thin and attending meetings, but when the topic is relevant, we want to make sure that it is available to you all. We have a monthly meeting that is actually our national e-consult work group. This is a project of California Healthcare Foundation. And next month, February, we are holding our monthly e-consult work group on e-consult for hepatitis C. Some of you have been on our calls before when Delphine Tuo, who is a UCSF nephrologist, shares expertise. She's been doing this for over 10 years now. And one of her colleagues recently presented or published a study on the efficacy of e-consult in addressing Hep C for primary care or in primary care settings. And it was a great study that showed through use of e-consult, they were able to get more than 200 patients visits that they would not have gotten otherwise. E-consult streamlined the process, making more space available to see those patients that actually needed to be seen in person. So just a great example of e-consult efficiency here. And that link is in your newsletter also, if you'd like to take a look at that study that came out last month. Here is our website, in case you'd like to see any of these publications, our newsletters, and our monthly webinar recordings, as I mentioned, and you can see our websites right there. So we wanted to keep this short and sweet today because we know how much you have going on at your clinics. Just a couple of dates to make sure you have your calendars marked. Our next eConsult work group meeting on Hep C, as I just mentioned, February 8th, and the CME, the registration link in your chat. It's open to others, not just clinicians. Anyone who'd like to learn about eConsult for behavioral and mental health is welcome to join this. If you'd like to receive CME for this, the registration link is in the chat. And any other comments or questions? Great, I'm just going to stop for a moment. Mark Schreier from California Health and Wellness, did you have anything you wanted to add?
Hey, Libby, thanks for the opportunity. So this is something that, like, others have said on the call, we've been supporting for many, many years with early adopters, and then, scaling across the state. So right now, I live in Plumas County. We're really impacted by the wildfires. There's the COVID pandemic going on. And I really think that there's no greater need right now, no greater time to implement. So to support our members in their ability to be able to get early access to care, and not have to travel and be, have that challenge and burden placed upon them. So if you're an organization that hasn't implemented, you're considering implementation, please reach out to us. We're happy to support you. Just let us know. Thanks, Libby.
Thanks, Mark. As we wrap up today, Corinne, anything else you wanted to add?
No, nothing else to add. Thank you, everyone.
Thanks, Karina. Okay, everyone, please do take a moment and share that information about our upcoming CME. We hope to see your providers on a call, and keep us abreast of anything that you need specific to your clinic. We look forward to seeing you next month. Thanks for your time.
Thank you, Libby. Bye-bye.
Bye.
Thank you.